angiotensin receptor blockers,
Mhm.
ARBs. Really vital stuff for you medical students.
Absolutely, especially if you're following along with KMR Advise on YouTube. We want to make this crystal clear.
Exactly. Our mission today is to unpack how ARBs work, their clinical uses,
Mm.
basically the essentials you need for practice and, well, for exams too. We'll be using our flowchart and summary table to guide us.
Sounds good. So let's start right at the beginning. A patient takes an ARB, perhaps losartan or maybe valsartan. Telmisartan is another common one. These are typically oral medications.
Right. They swallow the pill, and then
Hmm.
what happens inside?
Well, it gets absorbed usually from the gut and enters the systemic circulation. That's just, the main bloodstream.
Okay.
And the really neat part is how specific they are. ARBs selectively block one type of receptor, the angiotensin type 1 receptor, or ATR.
EPR. And where are those found?
They're in quite a few key places. Blood vessels, the adrenal cortex, that gland sitting on top of the kidneys, the heart itself, and the kidneys too.
So by blocking those receptors, the ARB stops angiotensin II from doing its job there.
Precisely. Angiotensin II normally binds to ATI, and one of its main jobs is vasoconstriction, making blood vessels tighten up.
Okay.
By blocking that binding, ARBs prevent that tightening, so you get vasodilation. Instead, the vessels relax and widen.
Which lowers resistance.
Yeah,
It makes it easier for the heart to pump blood, right?
exactly. It decreases what we call peripheral vascular resistance.
Got it. And you mentioned the adrenal cortex as well.
Yes. Angiotensin II binding there normally triggers the release of aldosterone. Aldosterone is a hormone that acts downstream in the kidneys, in the distal nephron.
And what does aldosterone do there?
It makes the kidneys reabsorb more sodium and water back into the body. So by blocking ATR receptors, ARBs lead to less aldosterone being secreted.
Meaning less salt and water are held onto.
Correct. So less sodium and water reabsorbed.
Yeah, so that reduces the amount of fluid in the bloodstream, which also helps lower blood pressure.
Yes, exactly. It reduces the blood volume. This decreases both preload, that's the stretch on the heart before it beats, and afterload, the pressure the heart has to pump against. The end result is lower systemic blood pressure.
Makes sense. Now, you hinted earlier, there's a key difference compared to another common class, the ACE inhibitors.
Ah, yes. A very important point, especially clinically. Unlike ACE inhibitors, ARBs don't really lead to a significant buildup of bradykinin.
Bradykinin, why does that matter?
Well, bradykinin is thought to be the main culprit behind that nagging dry cough some patients get with ACE inhibitors. And sometimes, though less commonly, it can cause angioedema, that serious swelling.
So because ARBs don't increase bradykinin much, they have a lower risk of causing that cough and angioedema.
That's the key takeaway. It makes ARBs a really good alternative if someone can't tolerate an ACE inhibitor because of those side effects.
That's a super useful distinction for students to remember. Okay, so we've covered the how. Let's move on to the when, the clinical applications.
Right. So the big ones are treating hypertension, of course. Also, slowing down the progression of diabetic nephropathy, that's kidney disease related to diabetes.
Okay.
And they're important in improving survival for patients with heart failure, and also after a heart attack, a myocardial infarction, particularly, again, if the patient couldn't handle an ACE inhibitor.
So hypertension, diabetic kidney disease, heart failure, post-heart attack. Quite broad uses.
Yes. And actually, sometimes they might even be considered for their kidney protective effects in patients who have microalbuminuria, small amounts of protein in the urine, even if their blood pressure isn't technically high yet.
Interesting. Now, thinking about exams, viva voce, what are the absolute must-know points for students regarding ARBs?
Okay, key things. Major adverse drug reactions, ADRs. Number 1 is hyperkalemia, hypotassium. Monitor that. Hypotension or low blood pressure can happen, and potential changes in kidney function, so we watch serum creatinine.
And importantly, remember the lower risk of cough and angioedema compared to ACE inhibitors.
Definitely mention that. Then, drug interactions. Be careful combining them with potassium-sparing diuretics or potassium supplements because of that hyperkalemia risk.
Right.
Also, NSAIDs, non-steroidal anti-inflammatory drugs, can sometimes make ARBs less effective and might increase the risk of kidney problems.
Good to know. Are there times when ARBs absolutely should not be used? Contraindications?
Yes, big ones. Pregnancy is an absolute contraindication, potential harm to the baby. Also, bilateral renal artery stenosis if both kidney arteries are severely narrowed, and generally avoided in severe renal impairment.
Okay, clear contraindications. And what needs regular checking when a patient is on an ARB? Monitoring.
You need to monitor their blood pressure, naturally, check serum potassium levels, and keep an eye on renal function, usually with serum creatinine tests.
Perfect. And just to really emphasize for our listeners, especially the students tuning in via KMR Advise in India. We're keeping the pace steady here. Remember those key indications: hypertension, diabetic nephropathy, heart failure, post-MI, particularly if ACE inhibitors aren't tolerated.
Exactly. We hope this detailed walkthrough is helpful for your studies.
Please do share this deep dive if you found it useful. And subscribe to KMR Advise for more explanations like this. And, hit that bell icon so you don't miss out.
Okay, so quick summary. ARBs block angiotensin II at the A-tier receptor. This relaxes blood vessels, reduces aldosterone, lowers blood pressure. Key advantage: less risk of cough than ACE inhibitors.
Making them crucial for hypertension, diabetic kidney disease, heart failure.
Right. Which leads us nicely to a final thought for you all to consider. How might a patient's specific comorbidities, their other health conditions, influence your choice between using an ARB versus another type of antihypertensive drug?
That's a great question to ponder. Really thinking through these foundational concepts is just so critical as you move forward in your medical careers.